to the Plus Sides podcast. We're so glad to have you back. So today it's going to be a little bit different. We don't have a community guest. We are in season 2, so we won't take too much time explaining what this is and what we do, but we're going to keep it quick. So today we're going to be talking about preventative medicine. This should be interesting, using GLP-1s to treat you maybe even before you have significant weight issues. And it's controversial and there's a lot of bias, but we are going to educate with our doctors who are specialists in this area and try to move things forward. If you don't know me, I'm Kim. Where you been? What you doing? We're in season 2 now. But we're so glad to have you here. I'm a little cold nastiness, so I apologize for that. But we are really working on trying to change things with the podcast and to be able to get loud. We want affordable access for anybody to be able to access these medication and be able to change their lives and better their health, because that's what it's about. But mental health is a big piece of that. And calling things vanity, I don't think is fair. And so we're going to talk more about what that means and understand the clinical side of it with Dr. Salas Whalen. Huh? I said it right? Yes. And I will invite her in shortly, but I just want to make sure we do rounds real quick so you know who Kat and Janine are. Kat, who are you? Why are you here? What's up?
I am Kat Carter. I have been on Manjaro. I'm saying it like a non-Midwesterner.
I like when you say Manjaro. I like when you say
Manjaro. I just can't. I can't. It's just, yeah. I've lost, let's probably 67. I've lost more since once I've been kicked up to 15 milligrams. Really, and that's it. I'm been on it. No more food noise. I'm a binger. And I'm really excited about this episode because an ounce of prevention is a pound of cure. So
indeed, maybe that's what she was.
And it's clever. And the only vanity in my book was Prince's Vanity from Vanity Suite. So we're just gonna.
Is that a song or is that a tour? I don't know. Pop culture friend.
Okay. Vanity, Denise Matthews. She was a very beautiful woman.
Oh, yeah. Okay.
Anyway,
JT, who are you? What you here? What you doing? What are you here for? Who are you?
Jet lag, but but yeah, I'm the Janine. I'm Janine Trot, the Janine on TikTok and Instagram and all the socials. Struggle with late in life obesity. I'm a type 2 diabetic, as well as I have a autoimmune disease, Sjogren's syndrome, which is gaining some traction. People are now talking about it, which is a good thing.
We got to talk about it. We got to talk about it.
Yeah. We like never used to talk about it, but now I am on Mounjaro. I think it's like Kilimanjaro. It's supposed to be like that. And you're climbing the mountain of getting better. Yeah. So, but I've lost 41 pounds. My A1C is now under control, and my numbers just look great. So it's definitely a marathon and not a sprint.
That's right. And we've been talking a lot lately about, childhood obesity and the different things that exist here, and the fact that we can test for genetic things. And I think that's a big deal. We got to talk about it. We need a better future for our children. We need
definitely.
That. So
definitely.
Let's find a way to change things. So if you are on the fence between if people with, that appear to be thin, that want to be thinner, should not be taking these medications, we're going to try to help today. Okay. And we are going to do that with the help of Dr. Salas Whalen. Hello, welcome. We're so glad to have you.
You should see my big smile when I'm hearing all the introductions and your journeys. I mean, that takes a lot of vulnerability, and I see it with my patients to be able to talk about this. So I'm really grateful that you guys are doing this, because I feel this is really going to change the way that our health is, our longevity.
Yeah.
I hope so. We're definitely trying to bring a voice to people that have been, I think, marginalized, ignored, for so long. And I think science has caught up now, and now we have to help society get there. Yeah. And if we just sit in the room with people that look like us and sound like us, nothing's ever going to get better.
No growth.
Nope.
There's no growth. Exactly, Kat. No growth. So we are so glad to have you here today. I would love for you if you could just take a minute to tell us a little bit about you for people that don't know you, which we know are not many, but just in case, and tell us who you are and how you help people.
So I'm Dr. Rocio Salas Whalen. I'm an endocrinologist and obesity board certified physician. I'm from Mexico originally, but I've been living in New York for 21 years, and I practice here in Manhattan as my office. And the way that I help people is, I would say 99% of my practice is obesity and weight loss. And I've been very humbled, and I feel like we owe people with obesity a apology, right, as physicians, because we didn't know. I didn't know. I wasn't trained. When I was learning about obesity and weight loss, it was always like on the scientific side, right? Because that's our profession, but we never
Right.
learned about what's happening on the patient side. And that's been really an eye-opening in the way to treat obesity, right? It's not the eat less, exercise more, because patients have been doing it for years, for decades, and we
Yeah.
keep bouncing and saying the same thing. But finally, now that we can actually offer treatment, I feel like there needs to be more acceptance of medication, acceptance of obesity as a disease, because only then, as you mentioned, we'll be able to get and move forward in
Yeah.
health.
Yeah.
Exactly. That's awesome. I got to tell you, I love when I hear people that are double certified. I like, especially like people that have considered endocrinology and like the role it plays in this. We've learned so much about that over the past, what, 5 or 6 months we've been doing this now, which is really great. So I love that. I hope we see more of that. I really do. Because they are so related, and we'll talk about that more today. So speaking of that, thank you for the lovely intro. We would like to know more about metabolic disorders, like what that means, what's going on in the body. And then when you're trying to understand if you have, a metabolic disorder, what kind of blood test or things like that would a doctor do to be able to figure out if that may be an underlying cause?
So metabolic disorder, it has to do with metabolism. Metabolism is the way that we process energy from food and glucose in our body, right? So there's many pieces that have to fall together for proper metabolism to happen in the body. So metabolic disorders is anything that is disrupting any of that perfect machinery in our body called metabolism, right? And there's several metabolic disorders. The most common is type 2 diabetes, fatty liver, insulin resistant, hyperinsulinemia, high cholesterol, high blood pressure, right? So those are metabolic disorders. I mean, some of them disorders can be hereditary or other genetic causes, but the majority definitely is caused by a metabolic disorder. And I think it's mostly with your yearly visit, right? Your blood pressure, your glucose, blood tests, including an A1C, which is a 3-month average of your glucose control. Ideally, body compositions, right? We're moving way away from the BMI. Thank God
Good.
for that. Exactly. Those are
Applause.
because we didn't know what we were. With BMI is just a multiplication between your weight and your height. Is a calculation, right? But it
Yeah.
doesn't tell us what's muscle, what's body fat, how's body fat distributed. In going into metabolic disorder, visceral fat is really important, right? So
Yeah.
your physician should be measuring your waist if they don't have a body composition machine at the office, right?
I've never had anybody do that measurement ever in my entire life. And I have been obese probably
Wow.
since I would say 10.
Really?
So no one's ever measured
That's
my
very
waist.
interesting.
Yeah. And I was even active and things like that. Like it's never
Yeah.
been a thing. It was always, she's not active enough, or
Very interesting.
and they're not wrong. I had an eating disorder. Like, but I think a lot of that had to do with control and stuff. But I also think a lot of that had to do with, you know, the biology of it. Obesity runs rampant in one side of my family. So
And I
yeah.
don't know if I can jump in, and I just want to say something that we're
Yeah.
moving into first people language, right? So we are moving the disease from the person. So in case
Yeah.
now with obesity, we see the people with obesity, or I had obesity, not that I'm obese, right?
Yeah.
Because this
Okay.
you are you, and you are not your disease,
I
right?
love that.
And
Yeah.
with diabetes, we don't see, the diabetic patient. No, the patient with diabetes, right? So we're
Yeah.
putting people first and then disease later. They're not your
That's
disease.
awesome. Yes. Language is
So I'm a
important.
person
Words are
with
important.
obesity,
Yeah.
not an obese.
Thank
Okay.
you. Yes.
Yeah.
That's
That makes sense. I'm a
major
person with obesity.
The person
Yeah.
with obesity.
with
All right.
obesity.
Everybody remember that new wording. It's important.
Yeah.
So in terms of like metabolic order and the whole idea of like disorder and the part of like insulin resistant, I feel like we hear a lot about how that's explained. I'm not sure it lands well with everybody, even people who struggle with it. Like, can you sort of explain that? Like how we had an episode with Matt Indo about sort of the spectrum of insulin resistance. We went into it a little bit, but some of the feedback that I got was, can you go into it a little bit more? Because we want to know a little bit more. We want to understand, these disorders and these diseases a little bit more. Is that something you can expand on for us, please?
Yeah, definitely. So, insulin resistance and hyperinsulinemia are the earliest signs for type 2 diabetes, right? It's like the very early stages. That's how we develop type 2 diabetes in our body, is from insulin resistant and hyperinsulinemia. So, our pancreas is the one that is in charge of producing insulin. Insulin helps the sugar that we eat in food, the glucose that we eat in food, to go to the proper places and open those channels for the glucose to act um, as energy, right? As fuel for our muscles, for our brain, for everything.
Yeah.
Insulin resistant means that your pancreas is constantly stimulated to produce insulin. So every time you need more and more and more insulin to have the same effect, right? So that's hyperinsulinemia, because you're producing too much, because you're insulin resistant. You're resistant to the same level. So every time you need more and more and more to have the same effect in your glucose control, that at one point your pancreas gives up, and then that's when we develop type 2 diabetes.
Ah.
Insulin resistant promotes visceral fat. Visceral
Mm.
fat promotes insulin resistance.
Wow.
Then patients get into this cycle, right? That you're more insulin, more visceral fat, you need more insulin, and then more insulin, you promote more visceral fat. So then you get in a vicious cycle that is very hard to get out of it.
Yeah.
Can insulin resistance, because does it play into your appetite or your hunger hormones, or is that separate from
Well,
insulin
insulin
resistance?
is a growth hormone, right? Insulin is a growth hormone. So that's why there is increase in appetite, there is increase in weight. So always the less insulin, the better, but the more insulin, like somebody we're treating with insulin, even my patients with type 2 diabetes, or patients with type 1 or type 2 diabetes, more insulin, there'll be more waking, more appetite, because it promotes
Okay.
growth.
Oh my
Okay.
goodness. No one's ever said that to me before. That makes so much sense.
Wow.
Yes.
That wow.
Thanks,
Okay, so
Dr.
yeah,
Salas.
Yeah.
I
Yes.
just had like a huge light bulb moment, and I know that I never really had heard of insulin resistance until this year. And I've learned so much, just like everyone else, but obesity and type 2 diabetes are considered chronic diseases by many. And we're told by obesity specialists and endocrinologists that chronic diseases need to be treated for life. So chronic diseases need chronic treatment. So, what would you say to someone who doesn't want to be on endocrines long term? And how is weight loss maintained if the medication is stopped?
So let's go back a little bit. We have to take a step back for people to understand why they're designed
Right.
for long term, right? So whenever we think of obesity, thank God that we are beyond the calories in and calories out, right? We are beyond the what you're eating and what you're not eating, or what you're exercising or not exercising is causing obesity or weight gain. We know it's a multifactorial problem, right? It's not just lifestyle. I like to break it into 5 causes. One is lifestyle. Yes, it can contribute, but it's not it. We have genetic factors, hereditary factors. So about 40 to 50% of obesity is genetic, and we can talk a little bit about that also in prevention. We have hormonal changes, insulin resistant, promoting visceral fat. We have PCOS, which promotes insulin resistant, menopause, perimenopause, or hormonal changes to a person's life. Aging, it's another determinant, because definitely after a certain age, our metabolism starts naturally to slow down. And then we have the last one, which is environmental factors. Environmental factors is at even the BPA that we were exposed growing up, right? Endocrine disruptive chemicals, toxin, pesticides, traveling for people that have to be traveling internationally, jet lag, people that don't sleep or that
Mm.
night. Those are all considered environmental factors that can promote obesity. But if you think about it, the only thing that patient really has control is one piece of the equation, right? So when we put somebody on medication, we are helping with this. And that's why certain diets can take you to the goal when they become severely restricted, right? Because we're taking care of this. But the moment that that restrictive diet that is not sustainable long term, everything else is going to promote weight gain again. We're not curing all the other factors. We're just controlling it. Same concept with weight loss medication, with incretins. We're controlling this, but the moment that we stop it, everything else will push back to promote weight gain, right? So
Wow.
it's not the medication. It's not that you're going to have a rebound weight gain. It's just that all the other factors are going to be there. And I always I ask, what medication works when you don't use it? Like it's like
True.
we puzzle people think
Yeah.
that the medication that you don't use is going to have an effect when you stop using it. It's
Yeah.
Yeah.
Obesity is a chronic disease. From all these things that I mentioned, that's what makes them chronic. It's not necessarily curable. And as we treat type 2 diabetes, hypertension, high cholesterol, arthritis, I mean, many other chronic diseases, right? This is one of them. But if we think about it, all those chronic diseases that we have and that we can treat and that we build specialties around it, were most of them caused by obesity.
Yeah.
Think about it, now we can treat obesity. We're going to prevent so many other chronic diseases. I predict that we're going to have less type 2 diabetes, less cardiovascular disease, less osteoarthritis, less fatty liver, less hypertension, because
Yes,
we're
indeed.
we're being very proactive in preventing them from developing. We don't have to wait until the patient exhibits an A1C of 6.5. They're pre-diabetic, right? For us to be proactive and do something about it.
Yeah. I love. How come this is misdiagnosed so often? Because like for me, I used to have horrible pains for like 3 weeks out of the month. I have all of the symptoms of PCOS, but when I went to my OB and said, "Hey, something's up. Like I'm not getting pregnant again. I don't know what's going on." And he's like, "Well, I'm not putting on anything and I'm not doing any tests because you ovulate." Because I had been pregnant 3 times even though I had miscarried twice.
Mm.
And it was nothing. But I have all the symptoms, but I didn't know enough to advocate for myself to figure out what that is. And the difference that I have had on my cycles since this medication, like I don't have pain anymore. And I can't help but think that that has to be what it is, but I don't know how people test for it and like figure out how that works. I've always had cysts. I know that because they've seen them in ultrasounds when I was pregnant. And but nobody's ever been like, this is the thing, and try metformin or anything else like that. So one, why is that misdiagnosed? Because I know that's something that you talk about like in your bio that you work on, and like how that works with insulin resistance. And also like how do those two things play together and then cause obesity?
So it's very unfortunate that many women are misdiagnosed or takes it. Well, it actually takes about 5 years for at least 5 to 10 years for
Goodness.
a woman to be properly diagnosed with PCOS, right? Which is a shame. And PCOS, what I see in my practice, PCOS, and we'll talk about symptoms and what it is, PCOS, but it can also
Great.
give mental health symptoms,
Yeah.
anxiety, right? And I see many patients stopping first at the psychiatrist and being put on anti-anxiety medication when all it was PCOS, unfortunately, right? So I would say, talking about that, is I found that patients really know their bodies. We don't know your body. I don't know your body as well as you do, and as you do. And whenever something feels abnormal, that okay, this is not right. Something is happening. Be proactive and find the doctor that is going to listen to you.
Yeah.
Right? We as physicians have a responsibility, but you as patients also have a responsibility to advocate
Yes.
for yourself and
Agreed.
inform yourself and educate yourself. Right? I always feel patients that are educated do the best in their treatment,
Yes.
right? Because it becomes more as a partnering work.
Yeah.
So PCOS, the name is polycystic ovarian syndrome, which is a bit misleading. And actually, there's been talk about removing it, the name, because many people associate it. If you don't have a cyst in your ovary, you don't have PCOS. And I think that's one of the reasons that many times is not properly diagnosed,
Yeah,
because
totally.
people are waiting to see the cyst in the ovaries. And well, actually, that's not the main problem. There's 4 criteria that we use to diagnose PCOS. And now GYN and endocrine have a little bit of difference in the criteria, but as per endocrinology, we use
Okay.
4 criteria, but patients only have to meet 2 of them to be diagnosed with PCOS. One of the criteria is irregular menstrual periods, right? And by irregular, I always explain to my patients, it doesn't mean that you 6 months without a period, 1 month without a period. It could be just unpredictable cycles, right? So that could be irregular menstrual periods. The second criteria is external symptoms of too much testosterone, which is the main problem in PCOS, is a hyperandrogenism. So facial hair, chin, neck, breast, thinning of the hair, especially like we call it a male pattern baldness. You start losing hair around here, acne, oily skin. Those are clinical symptoms of too much testosterone. It could be anxiety too, heat intolerance, trouble sleeping. Those from the high testosterone. That's the second criteria. The third criteria is chemical proof or chemical elevation of testosterone and DHEAS in your blood work, right? And last is pelvic ovarian cyst in a pelvic ultrasound. So you don't have to have the 4, so you can have 2 of them, the irregular periods and the clinical signs, and not necessarily have ovarian cyst. And I think that's what, again, the name is very misleading and misleads some people in not doing the proper diagnosis, right?
Yeah.
Now, in PCOS, the main problem is that in the ovaries and in the adrenal glands, we're making too much testosterone versus estrogen, which is the majority of the hormone that the woman makes, and that's what makes us female. Now, hyperandrogenism promotes insulin resistant and visceral fat. Visceral fat promotes hyperandrogenism. So again, we go into that little vicious cycle, and that's how the two are.
Wow. That's fascinating. That's awesome. I'm also wondering, like, when you get to the point where they're looking like to see if you have cyst on your ovaries, it's like, how do you even ask for that? I feel like people push back so much on, hey, can we please do an ultrasound to see what's going on? Is that going back to, just coming in and feeling like you're educated in that area?
I think you should go to an endocrinologist, right? If you discuss it with a GYN, because we see this every day, right? We see this
Yeah.
multiple times a day. So you have to go with somebody who's gonna go beyond. I mean, I don't do pelvic patients if they have 2 of the criteria, then I
Yeah.
start treating, right? And definitely we know, and a caveat here is that we know that obesity and PCOS go hand in hand, right? If obesity, if the weight goes up, the symptoms of PCOS go up. If the weight goes down, the symptoms of PCOS improve. We don't know really which one comes first. We just know that they fit into each other. There's a very small percentage of normal weight women with PCOS. So that may be another reason why maybe sometimes it's disregarded or not having PCOS, because this is very strong association with obesity.
Right.
Yeah. One of our, so another person on our team specifically asked, like, back to the PCOS and insulin resistance. She was like, she used this wording, and I haven't heard it before, so I'd love to know, like, if that makes sense. But she said, how do the incretins treat the issue with blood chemistry when you have PCOS and insulin resistance? And I'm not sure if that's like the proper phrasing, but it's again, like, this is like things we've heard, and we're not sure if that's the right. Could you explain that for us?
So again, in PCOS, there's high insulin resistance, high visceral fat, hyperinsulinemia, and that's why people with PCOS are predisposed to developing type 2 diabetes later in life. Incretins decrease insulin resistance, decreases hyper, because it gives, I like to say that it gives your pancreas a break, right? It gives your pancreas a break from working 100 miles per hour, being an overload of work. The incretins take care of that, and then your body can start to decrease hyperinsulinemia, and this decreases testosterone, DHEAS, then it starts to improve the symptoms, your fertility increases, your cycles start to become regular. So that's the connection between incretins and PCOS.
Wow. I keep looking back, like, it's interesting on my life, and I think I really wanted more children. I really did. And, like, I'm learning so much about this house. I'm sorry I'm getting upset, but, like, it's just so validating hearing all of this.
Yeah,
But I really did. I really did. And I hate that 10 years went by and, like, I didn't know about any of this. Like, what would my life have been like, if I had been treating this 10 years ago, you know? And I think that kind of goes into, what I was talking about in the beginning is, like, I'm sorry I'm getting so upset. I'm on my period.
It's okay. You don't have to make excuses. You're allowed to be upset.
Look, this is a vulnerable show. You know what I mean? But I really wanted to talk about that because I think that we see, and more and stuff pops out on the media of like people just being ridiculed if they look thin and they're trying to be thinner, whether it's because they've hit perimenopause or menopause or they have issues with their thyroid, right? Like those kinds of things. And I'm wondering a couple things. One, I've heard a lot about thyroid issues and weight, right? And I'm curious how that plays into any of these different medications. And I'm also wondering like how you feel about if someone came to you and maybe they've been playing with 15 pounds, right? Their whole life. It's been like 15, 20 pounds. They did a diet, they got it off. Eventually they gained it back. And it's kind of just been the normal like yo yo, right? If they come to you because maybe they're at a certain age or at a certain point where they're like, I don't want to play with these 15, 20 pounds anymore because they know that it's sort of headed in the direction of when they get to menopause or when they get here. And maybe none of those things have shown up yet on blood work, right? Or maybe they haven't even asked, or maybe the doctor hasn't even tried. How do you feel about possibly treating someone that looks thin and maybe appears to be healthy, right? To prevent them getting sort of like on the other side of a BMI they don't want to be on, or an other side of an A1C that they don't want to be on. Because I feel like a lot of the problem right now is that we are very much thinking, like we mentioned in the beginning, you were like, hey, like I think that we're getting to the point where we're thinking about this as preventative medicine. I think that doctors are getting there. I don't think society is. If anything, I feel like as someone that struggles with obesity, see what I did there? I did what you taught me. That struggles with obesity, that I still get so much hate for taking a medication off label, to treat this. And I think even if I didn't, I still get you're fat and lazy, eat less, move more, and all of those different things, like those other pieces that we discussed, and I don't think society's quite there yet, but I want them to be. So as a doctor and a specialist in this area, how do you feel about treating someone like that, somebody that's very early?
It's really, again, treating patients with obesity has really been eye-opening as a
Yeah.
person and as a physician. And I try to teach that because the practice that I have is very unique. I can spend 1 hour with my patients. I spend half an hour with my follow-up patients. I'm allowed in that hour, in that 30 minutes, to go dive deep into
Hmm.
the story of each patient, right? And learn about
Yeah.
each patient. And that idea of the patient with obesity, that it's lazy and that's they don't not doing anything. I mean, I haven't met a single patient with obesity that is not active or that it hasn't tried in a certain way to lose weight in some point of their life or every day in their life, right?
Yeah.
So we're very easy to jump into assumptions
Yes.
when we really don't. I didn't really know, even treating patients with obesity, that patients were struggling so much that they take 24/7 for some patients, right?
Yeah.
It involves every time you put food in front of you or you're thinking of food or a snack, what impact is going to have in your weight. Should you eat it? Should you not eat it? If you eat it, you feel guilty. I mean, it's a constant struggle that I didn't know, right? So I feel like we should not assume that somebody that has obesity is not trying, number one. Second, after almost 2,000 patients that I've treated with obesity, if somebody walks in my office, I still don't know who will benefit and not from the medication just by looking at somebody. We are associating weight and health with how somebody looks.
Mm-hmm.
Unless they have X-ray vision, they
Yeah.
cannot say
100%. Yes.
anything.
Thank you.
Nobody's weight or
Applause.
right,
Yes.
because I have to do certain studies. I have to do body composition tests and say, okay,
Yeah.
I'm looking at the visceral fat, I'm looking at your percentage body fat, I'm looking at your muscle mass. Your BMI could be 20, but your visceral fat may be so high, your percentage body fat may be so high that you require treatment because you can still develop type 2 diabetes and metabolic problems, right? We have, when we look at somebody, we're just looking at their total, right? But internally, what I find many times when we see a normal BMI, it's normal because they have very low muscle mass. They have high body fat and very low muscle mass. And
My
in a simple
goodness.
calculation, it averages up as a normal BMI, right? But when I start seeing the body composition, many patients that And they come and they know their body. And once you see their BMI, if somebody else sees a BMI, they could say, no, you're with the normal range, right? But then when you see the body composition, they still will benefit from treatment because their visceral fat is high, because their percentage body fat is high, and their muscle mass is low, right? So we cannot tell who needs it, who will benefit or not, just by simply looking at somebody. Now, you did mention that somebody that has tried to lose 10 pounds, 15 pounds, and I've seen that a lot. But you have to ask yourself, and the patient has to ask yourself is, how restrictive have you been? How much does it take of your life to get 15 pounds out, right? To maintain those 10, 15 pounds. What extreme measures is that person doing to be able to lose that 10, 15 pounds, right? Is it worth it? Can we help them with medication? Can we relieve that burden that patient is struggling? We don't know what measuring somebody's doing to maintain or to lose 10 or 15 pounds. Right. So it doesn't happen easy. It's not like, oh, you can lose 5 pounds, just do exercise and eat less. For some patients, it's not working. For some patients, they're restricting their life so much, it's taking so much of their mental health that why can we not relieve them from them if we have the need for it?
Yeah, I think that's so true. And like one thing I realized recently is there was this song going around from this girl who appeared to me to be very thin. And she wrote this song about how she just wanted to be skinny. I don't know if you've seen that going around. And I shared it, and so many people were touched in the community, and other people were like, I don't get it. She is skinny. And I'm like, but you can't see food noise. Like you can't, and if somebody like, and there are people say to them, oh, well, you're just going to gain it back if you have the medicine. Why do they gain it back? Like something is going on, right? Like
Why do we
for
have
them
to
to
be
get
off
on
the
it.
medicine?
Why? Like right,
Yeah.
exactly. Like why would you stop taking medicine for illnesses? It just doesn't make any sense. And I think like, but the
I'll
fact
stop
that they're
taking
dealing with
vitamins.
it on the smaller scale, right? But like the fact that they're dealing with it on a smaller scale, I feel like it's just like not of consequence. It's like but I didn't used to feel this way. I for sure was like, what are they doing? They don't need this and all that. But the more I've learned from people just like you, I've been like, that is not a thing. Like you cannot see white knuckling, you cannot see food noise. Why would we not give them relief? Just like you said.
So
So
checking the
thank you so
bias
much
is
for
like,
clearing that up.
it's a
The
two-way
bias,
street.
the
You have to
bias
check
is a
our
two-way
bias,
street.
medical bias. Yeah, we have to check
Yeah,
it.
for sure.
That's very true.
Yeah. Yeah. I love it. But yeah, so I think JT, I apologize. I know you had a question. Feel free to jump in.
Look,
Sorry.
look,
She's covering all the things.
look,
Yeah.
it's I mean, because and I'll just say this because I don't want to take too much of Dr. Salas Whalen's time, but it's just that I've experienced that when we first started this podcast, there were people that were emailing Kim or communicating with her, asking her, well, is she really obese?
Like, how could she understand our struggle?
Correct. And look, and
bias.
I'm going to practice restraint,
Okay.
but but now I look back and that conversation shouldn't have even been entertained. It shouldn't have even been entertained, because that was a bias towards me. And that was a bias towards a person who struggles with type 2 diabetes, which that right there is a whole nother issue. I think that there's backlash on both ends, and I think it's education and advocacy. But our question was, what medications should patients and doctors be keenly aware of when starting a GLP-1 medication?
Oh, that's a great question. So I don't, if you guys follow me, I always say that the effectiveness of the drug and the decrease of no side effects or of side effects is going always to depend on the experience on who's giving you this medication, right? That is key. So always make sure that you're going with somebody who has prescribed this medication for years for many patients. You can ask how many prescriptions have they done, how many patients they've had, what is the success rate, what are side effects do patients encounter, right? Because that's really going to determine how you tolerate this drug, how much weight you're going to lose, and what's going to happen with maintenance too, right? So another thing that I want to talk a lot is about the decrease. One of the first things that we see improvement in PCOS and high blood pressure and glucose is as you guys are on the medication, you start eating much less, right? the food that we consume here in the United States and maybe the other places is very inflammatory, right?
Yeah, it's straight trash. Yeah.
The food industry needs to be held accountable
Yes.
of the obesity problem that we have worldwide.
Mhm.
Right? That's it. Like the tobacco industry, this is going to be the food industry, right? So as you start decreasing intake of inflammatory food, like the first thing that I see improvement in patients is inflammation, right? It's inflammation. Because of that, as you're consuming less things that are inflammatory, your blood pressure is going to improve, your glucose is going to improve. So if you are any other medication separate from incretins that was given to you as a purpose of decreasing your blood pressure, decreasing your glucose, the doctor that's giving you this medication has to be proactive and maybe being very watchful the first few weeks, because the blood pressure immediately almost improves, the glucose immediately always improves. So those medications that were targeting to take care of that may be too much, and the patient may have hypotension, hypoglycemia, right? So I would say medications for blood pressure, medications for glucose control, including insulin, sulfonylureas, glyburide, glipizide, any blood pressure medication should be monitored closely when somebody's starting incretins, because blood pressure improves almost immediately. Also, if somebody's in diuretics, right, it may be too much because you're already decreasing your sodium intake. So diuretics, hypertensives, and anti-diabetic medications, I think those are the medications that need to be monitored closely.
Yeah. That's awesome. I think that it's also a really big problem that there are not enough obesity specialists, and there aren't even enough endocrinologists. So I worry about our friends in our community that are in rural areas, and a lot of them have turned to telehealths. And there are some telehealths that have obesity specialists and then some that don't. And I think are kind of getting on, like, I don't want to be rude, but like sort of getting on the train, of the need of this, because the demand is so vast, because so many people are sick, and I worry about that. And I don't know what direction to give our community when they ask, because we talk with all these doctors. Like, what do you do to find one? And how do you find a doctor, even if maybe they aren't a specialist, maybe they have been prescribing for years? Like, what questions should you ask them to a place where you can create a good relationship? Because it's just like you said in the beginning, like it is a team, right? And I never thought of it that way either. Like, you are a part of these decisions. You don't just have to do what doctors say. You can talk about it, you know? But what would you say about that? Like, how do we get people more access to these experts?
I think this year there was actually almost double the amount of applicants for obesity medicine. So I think physicians are getting more involved and interested, because now we have treatment for it, right? Now we can actually do something about it. I think we got very frustrating as physicians, as patients too, to just beating the same thing: eat less, exercise more, I'll see you in 6 months, and nothing was happening, and everybody got frustrated. We stopped talking about it. Okay, let's concentrate on the complications, right? That's what we've been, the way that we've been doing. But now we can actually do something about it. So I do feel like there's more interest in physicians in doing obesity medicine now. What I do in my personal time is educate in social media, right? I think social media, yes, there's a lot of negative, but there's a lot of positive if you look for it.
For sure.
Social media, there's a lot of us obesity physicians that are educating, right? Making the consumer, making you, the patient, educated. So when you go who doesn't have the expertise, then you can ask the questions. You can say, okay, this is what I've heard, this is what I've read, right? You have to. It's your responsibility to educate yourself. And if you don't hear the response, the appropriate response, you can go to the American Board of Obesity Medicine website, which is abom.org, and you can see what obesity specialists are in your area. So that's a good start. If there's not an obesity specialist, and an endocrinologist will be your next best bet for somebody who has expertise on these medications.
What about bariatric surgeons that are starting to be like, hey, maybe we should not only treat with surgery, maybe we should consider these other things. Do you think maybe they would be a good option, or do you think they're always going to push surgery?
No, I think they're catching up. Like
So too.
surgery is not like in the last 4 years that I've had my obesity practice, I haven't seen nobody do bariatric surgery. Most that a patient has lost with me is 170 pounds.
Wow.
So
Yeah.
there's really no need with body. I mean, there's a lot of use of this medication in bariatric surgery, and I'm going to tell you how. Because with bariatric surgery, you're mechanically restricting, right? You're cutting part of the gut. So you tell the patient, okay, here is everything that you want to eat, but you can only eat this, right? This is basically what's bariatric surgery. But you're still going to want to eat the rest of the plate, but you just can't, right? So
Still got the weight behind the ears. Yeah.
they're not removing the food noise. They're not removing the drive. They're not removing the reward from food, right? You're not removing the anticipation from, and I feel it's like almost like a little bit of torture. Like you want it, but mechanically you can't. Incretins remove that, right? Incretins remove the anticipation of our reward. So for those patients that have bariatric surgery, and there's a lot of regain for many cases, it's because of that food noise, that eventually the patient, that food noise will overrun the effect of the surgery,
It
right?
wins again.
That's why adding an incretin to a patient that has bariatric surgery or had bariatric surgery is going to be very helpful, because they have already the mechanical restriction, but let's take
about how, and many people have come on and said the same thing. Like, I remember the moment that my emotional center like disconnected from my body, where I was like wanting to eat food and then like, oh, and my like normal habits. And then me going, I don't really want that. And me going, what just happened? And I had always soothed with food. So I didn't know what to do with myself. So I think that extra piece of like therapy, of figuring out like it's a very emotional experience, this process, and you kind of got to do all the work, like that's the thing, is we do talk about it as it being work, but I think that it's not like necessarily the kind of work that we're thinking, where it's like restriction and exercise and punishing yourself in the gym and 1,000 calories a day. It's not like that. It's, let's think about your health as a whole. Like, and that includes the mental piece. Cause just like you said, like I have had severe anxiety, like obsessive anxiety, the majority of my life. I mean, like I would unwind my day in my head before I would go to sleep, or I would have to download with my husband, and they were absolutely ridiculous. Like looking back, worries, I couldn't control it. And when I got on a certain dose of this medication, it turned off like a switch. And it goes back to where I think you were talking about, like sometimes they go to the psychiatrist to try to deal with this anxiety, and then you actually figure out it was like biological, And I hope that moment that you just had there, like our patients that are having that will make that connection and go and say, like, let's look at this, because that was really powerful. Thank you for sharing that. I have one more question, and then I'm going to let you go because I promised. But I really appreciate you giving us time. I know you have a super busy life, and it's very kind of you to contribute to our community this way. But I'm wondering, like, I sometimes think that even as patients, even like myself, sometimes I wonder, well, maybe I need to go and get a diagnosis, even though it really doesn't kind of matter because I'm treating all the things and it's all working. But it's like, how could I even go and get a diagnosis of metabolic order disorder or PCOS or insulin resistance if I've been taking these medications for a year and no one thought to test me for these things before? Would that even be something that you could do after the fact to like feel some validation, or is this something you should just kind of let go because it's probably not going to show, I guess, positive? I don't know if that's the right word,
Yeah, I mean, unless there's old blood work, right, that's showing something,
Yeah.
you can use that. But otherwise, I mean, thanks to the medication and your work, those numbers are not going to be there, right?
Right.
And that's the goal of the medication,
Yeah,
right? That's
right.
what we're aiming for. So yeah, I think it's just, as you said, if I knew about this medication 10 years ago, right?
Yeah.
It's hard to go back. Nothing is going to take us back.
Yeah.
This is what we have. And I think it's
No.
just the years that you have in front of you, that you know that you're going to have a higher quality of life, higher mental health, right? And there'll be more longevity.
The everlasting
Yes.
now.
Yes.
That's what we want.
Yes. I love it. Well, thank you so much for your time. The only thing I have left to ask you is, where can people learn more about you, and have more like education, like these things that we're talking about? Like, I've learned so much from your videos, and thank you so much for sharing that with everybody, including people within our community, so that they can learn and talk to their doctor and not have to live a life of being unhealthy, or maybe live a shorter life. So where can they learn more about you and follow you?
So on Instagram, my handle is Dr. Salas Whalen. And on TikTok my handle is New York Endocrinology. And my webpage is nyendocrinology.com. And that's where I post a lot of my videos, educational videos.
Awesome.
Oh, and
Thank
thank
you
you for
so
the tips
much.
on preventing Ozempic butt. I loved that video.
Yeah, I love it. I love when she was on a show recently and they were like, and they had already like trashed everything and they were like, oh, well, this isn't safe. And then you came on and you were like, and they were like, so there's not Ozempic
You
face. And
need
you were like, no,
protein.
that's just, you were like, that's just weight loss face. Like, it's not a thing, you know? And I was like,
Exactly.
You're
hell
not eating
yeah.
enough, yeah. And
I
increase your
love it.
protein. I was like, yes.
Yeah, like I
Thank you,
love it. It's so good.
ma'am.
We're going to be talking about Ozempic at the
Yeah.
Tanya Hall live show on Thursday. So if
Oh,
you
great.
want to look on the
Wow.
Oh, that's
like a
wonderful.
whole
Okay,
hour,
great.
they're gonna grill me there, but I'm good.
You got this. You got this.
Oh, you're ready. Oh, you're ready.
Yep.
You're awesome.
You're so used to
Well,
it.
thank you
You're a
so
pro.
much again. I do appreciate your time. And I will put all of the links to your bios and your socials in the show notes so people can follow you.
And I want to say thank you to you guys. Like, it makes me really happy to see a podcast like this that is really positive and talking about the positive things of these medications, right? Because you've experienced them. And I feel like when people go on this medication, it's like a almost blindfold gets removed of your head,
Yeah.
right? Like
Yes.
Mhm.
your perspective changes so much around food, right? Or like about portion control, about really, do I really want this? Do I really needed this? No, I
Yeah.
don't. I'm okay, right?
Yeah.
So I'm glad to hear, and hopefully more
Yeah.
positive places like this we can start seeing.
Yeah, I hope so too. We've gotten a lot of feedback from our community that said like this is healing for them. Like to be able to come and share their story, to feel camaraderie, to have other people. I'm telling you, every episode somebody reaches out to me and goes, "That sounds like me. I'm going to go see my doctor." Like, and think about how many people, gosh, if we could get other people so, spoiler alert. I mean, I guess everybody probably knows by now by the time this airs, but like, we had Dr. Contessa from Married to Medicine, and I am going to get Dolores. I don't gonna get her because she's fabulous. And I want her to come and talk about these things because it's important for us to remove bias for all to get in the room together. But I think that we really have to move forward like as a community of people that struggle with food noise, that struggle with this dysfunction. And we have to band together. And that includes our friends with type 2 to be able, because we are one community. We keep looking at it as these separate things and it's not, you know? So I'm hoping like by the work and by more people following and by my Facebook ads, people will come and like enjoy the podcast and continue to heal and be educated. And people like you that have helped us is huge. So I really appreciate your time and thank you so much.
Thank
I hope you
you.
have
Muchas
a lovely
gracias.
holiday weekend.
Have a great weekend.
So I can put it. So I can share it in my Instagram so you guys can.
Love it. And I'll send you some shorts if you want to promote them too.
Yeah, for sure.
Especially of all the aha moments because people are gonna be like, oh my God. So it'll be great. Okay. All right. Thank you so much. Have a great weekend.
Have a good weekend.
Bye.
Happy Labor Day.
I know,
Yes, happy
right?
Labor Day. Have a great Labor Day.
Try not to work. That's the whole point.
Bye.
All right.
Bye.
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 Oh my God, I love her so much. Love her so much. She's the best. I am so glad I got to have her on the show.
I wanted to ask her like 3 more questions.
The
They weren't on the
menopause
sheet.
questions.
Gosh.
They weren't on the sheet, and she was like,
Speaking of
I can
menopause,
do
yeah.
45 minutes. So
It's
Right.
yeah.
Look.
I know.
Well, we'll go to her TikTok. We'll find
Look.
everything.
Yeah.
Yes, go to her TikTok.
I was
Y'all
just
know,
Find her
like,
on
if
TikTok,
they're not
yeah.
on the sheet, we're not gonna.
I know. No.
Yeah,
No, but
yeah.
I mean, like in my head, the more
Yeah.
she talked,
The hunger
it was
hormones. I
just
had
like,
to know.
For sure.
oh, like
I know.
I'm like, oh,
I
wait
know.
a minute, you know?
Yes. I adore her. I've been trying so hard. She's awesome, y'all. She agreed to be on the show before Rosie, before anything else. And then for those of you that know, I had some illness in my family and I wasn't able to be that. And it's been difficult to reschedule with her because she's so busy and she's such a good advocate. And she's for those who struggle with obesity, for those who struggle with pre-obesity, for those that struggle with pre-diabetes or pre-diabetes. Like she's such a good advocate. And she goes on in the media and she's like, no. Mm-mm. This is why the thing. And she does it so eloquently. And so it's been very difficult to like reschedule with her. And finally I was like, please. And she recently posted a video about how she is, and you guys know representation is really important to me and to all of us, about how she's an immigrant and the things that she's been able to do, by coming here and the lives that she's changing. And I was like, please, we really want you to come on the show. And she was like, I'll make the time. and she did, and she made the time for us. She certainly doesn't have it, right? She made it for us. So it's wonderful. It's so great to have her. And I know we only got so much of it, but I hope we had enough aha moments, and like Journey, and like I have her email. If you want to send me, your questions, I'll send them to her. I don't have a problem with that.
It's
Yeah.
I mean, but again, and
Yeah.
I think just like hearing her explain it and really almost kind of deep dive into it, it just makes you think of other things. You're like, whoa, wait a minute. And I think that we focus so much on PCOS. We focus so much on insulin resistance. What about fibroids? What about this? There's a whole nother layer, and I'm not diminishing, but my mind just started going because I was like, whoa, wait a minute. And and it is so much more out there.
I have questions. I'll send them to you, Kim.
Yeah.
Any questions? I know. I bet you will.
Because I mean, like, I wanted to make sure that I didn't overload her,
Yeah, she only had so much time. She really did make time for us. Like, it is the weekend for all friends.
I'm so
appreciative. She is a mother, and she was like, I've only got this much time. I'm like, you know what? We will make it work. We will make it work. And I knew we couldn't get to everything. So I'm glad that she gave us what she gave us. But yeah, like, if you have more questions, and you know what? I'll even ask her, like, hey, is it okay if you answer these questions and like we do a TikTok about it, or we put something on the channel that's us asking these questions with her answers? Like, maybe that would be a different thing. So that way, like, people can get it, and then she can answer them written, like, in her own time. That might be a nice follow-up, and maybe like for bonus content or something for the YouTube channel. Like, we could do it that way. Yeah.
Cool. Or you know what? Or maybe she could do like a video. And then maybe
she's got time. I mean, we could send it to her and say, like, hey, you want to do a video on these things? But it's that goes back to like capacity. And like, if anybody understands capacity, like me right now, like, and it's like, you want to do so many things, but you can't. But like, if she's sitting down and she's got, 15 minutes to answer a few questions for us, like, I feel like she would probably do that. She's very kind, so
she is awesome.
Yeah. So anyway, but yeah, did you guys feel like it was good too? It sounds like you did. Sorry, I still got that cold.
You know what's so funny? I thought of this while you were having your conversation, but I got a little teared up too.
I did too. I'm sorry.
With taking this drug,
I did.
It has. We didn't have.
You cold soul, JT.
I know, right? We don't have children because. Okay.
Well, it's Virgo season.
Yeah.
I'm sorry. So I mean,
Go ahead, Kat.
I'm sitting here like, okay.
Go ahead, Kat. Go ahead.
This is good because we're laughing. When you got really like emotional, I was like, well, we didn't have kids because I wouldn't say we didn't try, but maybe the drug came too late. But I feel everything is in perfect timing. And even though we don't have kids, I thought it was okay.
Remember, there's a lot of people watching that are like this, so it's okay to be vulnerable. It helps
super
them.
fine with this.
I know.
But everything is in perfect timing.
Yes.
And you're giving birth to this. You're giving birth to another creation. So
we are.
Right. So everything is in perfect timing.
Okay.
I've had a lot of coffee.
Look. Okay, Kat.
Everything is in perfect. And let me tell you this.
Start to get a little teary-eyed. I thought I was holding on. Really good.
It's because you're jet lagged.
Gosh, look, gosh,
it's been a tough week. Not a tough week. It was my dad's birthday this week, and everything. So
mine too.
Everything is divine timing. So
it is.
Look, when things don't work out, you got something grander. And let me tell you, I don't have the patience for a baby.
I don't anymore.
I don't have the patience, and you know what? And here's why. Like I said, I'm very thankful that it didn't happen because, listen, having a baby after 40, no man.
Ooh, child. Look,
it's a lot.
Look,
it's a lot.
Ooh.
Like, don't get me wrong. If it happened to me, I get on board.
For a while, I tried there. No, ma'am.
I would get on board, but
I would not be.
Really did.
Because
you sound like me now.
We would have not upgraded this house. Like,
no.
Life would be very. And would we have had a time to do this?
No.
Yeah. I'm hoping that like the things that we're doing,
grateful,
and it's like
so grateful
like she
for
said,
what
I
happens
am.
now.
Yeah.
Just
And I don't know if we would have, if I had more children, would I have had time to do any of this? No. Like,
absolutely not.
or would I have had the aha moments and the passion to want to put, like, I mean, honestly, guys, like, I'm being honest, this takes a tremendous amount of time away from my family doing this. Like, I'm being honest,
Yeah.
but it is
Imagine, imagine a
it
baby
is
with
the
you.
joy and the
That's
honor of my life to be able
yeah.
to do it. It really is. And it does feel like we're creating something special. And it's so nice to have
Virus
people
with something
feel like,
else.
you know what, I didn't know. I didn't know. And I hope one day there's no need for us. I hope for one day
There's always a need for
everybody
us.
knows,
I think
you
it's
know?
always going to be a need.
You
I
need
think
our
it's always
smiles.
going to be a need.
Okay.
Yeah.
Always.
You need our
It's just
smile.
sad, but
It is.
that old saying where it starts with a pebble, and
It
when
does.
you put the
Mhm.
pebble, when you throw it in the water, it makes a
Yeah.
ripple, and you never know how you're affecting people. You
It's true.
never know who's
Yeah.
watching. You never know how
Yeah.
you're positively affecting people.
Yeah.
And I know this week in the community has been very emotional. I think it's been
It has.
very emotional for me.
It's that blue moon.
And
It's the blue moon.
but I mean, Kat's dad's birthday was this week. My dad's birthday was this week.
We both
I
lost
like
our dad.
always say the best gift he gave me outside of life was me being a Virgo, and I,
My dad was a Virgo
Virgos
too,
are
but I'm a
fabulous.
Libra.
see,
Oh,
but
how many
look,
tissues?
see, but I have seen, and I believe that we're aiding in opening the door. We're seeing a lot of vulnerability, or at least I've seen, and we've probably seen the same things in healing and people dealing with their emotions this week. I've seen so many TikTok videos of community members dealing with their emotions, and I'm like, oh my gosh.
Yeah.
Oh my gosh. You can feel, I know at least you can, I can feel it through the screen. And it's like a weight is being lifted off of them.
Yes.
The weight that we carry is the
Between these 2 ears.
fear.
Yeah.
And even if it's extra weight on the body, that's not the real cause. That right
Yeah.
there is the effect of something. And I love how we've opened the conversation of it's not just about the weight. I have said that from the get-go, and people thought I was crazy. And I was like, you think I'm crazy all you want to. I said, but
Yeah.
I am going to be like Iyala Van Zant right now. It's not
Beloved.
the weight. It is not
True.
just
It's
the
about
weight.
health. Yeah.
It is the
Uh-huh.
overall picture. It's the
It is.
mental, it's the emotional, it's the psychological, it's the
Yes.
physical, yes, which is still very important. And
Yeah. And that's okay. I
yeah,
think if you want, like, and that's something like Dolores said, right? Like, I'm gonna get her. That's something Dolores said
wanna
on one
get
of
her.
her videos, is she was like, when she was being asked in a very short amount of time, like, are you on Ozempic? And she was like, yeah, like I am. Or she was on Manjaro, I think she said, but she was like, yeah,
Zero.
I wasn't going to come to the reunion and be the biggest one. And I'm like, so
Yeah.
what? Like, I even as me, my size, I've thought that. Like, so what if you want to feel good and look good? God forbid. It's okay to want to look good and feel
Mhm.
good. There's nothing wrong with that. And it's time we
As long
talk
as we
about
don't,
it.
yeah, exactly. I was
Yes.
going to say, as long as we don't develop eating disorders or that's
Right.
the weight behind
Yes.
the
But
in between
people
the
are
ears.
Gotta be
However, I
real
assuming
get it.
careful
but
with
I
people
get
are
it. I get it.
assuming that because she's thin and just wants to be thinner, or because all of them, right, are thin and want to be, that they must have an eating disorder. Here's my whole thing. If they do, why? We need to talk about that.
Health
Why?
society.
Because the reason you and I did, right, is
Society for standards.
biological plus emotional. And all of the emotional stuff happened because we had the biological thing. And then they just, like she said, like it was just that constant one versus other, like chicken or the egg. You know what I'm saying?
Right.
So
Yeah.
if they're struggling, what's the struggle and why is it happening? Is it biological? Yeah, it probably is. And that's what the doctors are able to work through and figure out now, even if it takes a long time to do it. So, of course, they deserve medicine. Of course, they do, you know?
Yeah.
So, we're
Yeah.
going to talk about it now. We're gonna talk about it now.
Listen,
Yeah.
I am so glad that this podcast has taken the stand on that. And you always
Me
want to
too.
ask yourself, will you be on the right side of history?
Yeah, you do.
Will you be on the right side of history?
I just don't want people to be in pain anymore. I just don't want people to be pain. I think when you
I thought you said I don't want people to pee
experience
in paint anymore. Sorry,
no,
I was like, what
that
did you just
either.
say?
No pee in paint. No
Pee
pee
in
in
the
paint.
paint.
No.
Ma'am.
Ma'am. No,
Ma'am.
like I don't want people like once you take this medicine, it's
Ma'am.
very difficult for you to be like, not want to shot from the rooftop. Like that's what Dave says. Man on the Manjaro. If you don't follow him on YouTube, you should do it. And he says like we're basically like GLP1 evangelists because
Right,
we've
look.
experienced like hallelujah,
We're spreading the
hallelujah,
gospel.
spreading the gospel because it is incredible. And you know what? God does make miracles, and sometimes he does it through scientists, and that's okay. Like, like I'm just saying, hallelujah.
Look. Listen,
yeah.
I always come ready because
Yeah, you do.
I have an injection pen in my flight bag
so that you can educate and help people understand.
Listen, almost every trip, it's like, okay, this is what it looks like. People corner me in the galley. It's actually
good.
Scary, but I'm like, okay, let me
not
just
good.
get this out.
Good.
Yeah.
Like, I don't want you to feel cornered, but I'm glad that people recognize that you know a lot of things and that you can point them in the right direction to speak with their doctor and like the wording that they can use and the things they can ask about, which is what we want to do here. We talk more about the ripple. We talk more about PCOS and infertility and those different things. And like, I got to take a minute to brag on my kid. Because I know people have probably seen the TikTok, but honestly, like with the way the algorithm is, maybe not. But like we talk about these changes and these incremental things. Like my kid,
his booty blues.
His booty blues. He goes, Mama, stop looking at booty blue jeans. I'm like, no, duty blue. Stop looking at duty blue jeans. I'm like, baby, Mama loves her duty blues. Ain't nothing wrong with liking duty blues, But no, he said, I don't know if you guys know about it, but he said the teacher sent me a message at school and he said, and this goes back to the ripple JT was talking about, right? He's at school, he decided that there should be more apples in the cafeteria and he didn't like there weren't enough apples. My kid is on the spectrum and he has a lot of like issues with like food and textures and things like that. And so we're talking a lot about what equals nutrition, right? And how do we put the right kind of fuel in our body? And it's okay to have our lower grade fuel because it still gets us where we're going, but we want to take care of our car, right? I've mentioned that on another episode. And so he and I are talking about that a lot lately. And the teacher said, listen, like he actually went through and made a petition and got 100 kids to sign the petition to ask for more apples in the cafeteria. And, when I asked him about it, because I thought, how weird is that? 10-year-olds don't just go, hey, I want to start a petition, right? And also my kid, it struggles. So my again, like my kid is on the spectrum. So like social emotional, those are things that he has to overcome. And those are things that he is learning about like in school and therapy and those different things. But he took the initiative to get a petition and go around and get kids to sign it to get more apples in the cafeteria. And when I asked him about it, he said, it's like you said, Mama, you have to teach your kids to advocate. And I just like, I'm like, don't cry. But it's a good point because like I do spend a lot of time away from my family doing this. And I'm hoping that's the ripple because like, what else will he do? What else will he do in this life if he is going to put other people and think about them and lead with empathy, which we talk about a lot, like what else will he do? And what else can we do if we show that? Dinosaur monkey farts for president. DMF Junior. He does talk about when he's president a lot, but he also talks about being a scientist, a cowboy, a Ninja Turtle. Like, so I don't know. I think we can
find ways to put this all together.
Exactly. Yeah. Well, we will definitely see if we can get some questions to her. And honestly, audience, like if you want to make in the comments, if you want to write it, maybe I collect it all together and send it over. And maybe she'll make some videos when she gets a chance, or she'll send us questions and we'll make some, and I think she would do that. She's super decent, like really. Like I said, she agreed to come on the show way before the show was big, way before, so I'm so excited we were able to finally get her on. But I think this was a good episode. I hope everybody has learned something. Let's all try to check our bias at the door. If we can take medication because we're obese or because we have type 2, because we don't want to be that anymore, or we don't want to get there. Right. Thank you, Kat, because we have obesity. Yeah. You're so right. If we have that and we're really trying to do that, then there should be people who want to prevent obesity too. Yeah. And they should be able to take medicine too if them and their doctor decide that. And we've got to quit looking at people and just deciding it must be vanity because they look thin, or because they make a comment that they don't want to be the biggest person in the room. Everybody's always thought that before. I promise you, there's not one person that hasn't
We're
thought
all
that.
a little vain. Come on.
Of course, we're humans.
It's about you.
Especially in our society. Good God, but there's a reason we put on makeup. There's a reason we fix our hair. And a lot of that has to do with wanting to feel and fit. Like humans are very tribal, right? We want to be a part of things. We want community and we want to feel accepted and loved and involved. We don't always want to be this outsider. I think we're very tribal. And so I think that, in my opinion, it's okay. If you want to look pretty and wear some makeup, if you don't want to be the biggest person in the room, so feel that, figure out why that is and work through that, but I still think it's okay to have that feeling and make that statement because it's completely, in my opinion, a natural thing to have. So we're going to talk about it. We're going to find Dolores. I'm going to get her. I don't know how. Well, I'm going to try. Awesome. Well, ladies, let's do our classic sign-offs. We have a short episode today. Maybe people will like that. We'll see. I don't know. People fast forward through us a lot and they just listen to the doctors. Anyway, but yeah. So classic sign off for me. I feel like mine was let's make the ripple. That's mine today. Let's make the ripple because I feel like my kid is part of that ripple and I can't wait to see what happens next. And check your bias at the door. Those are my things for today. How about you, Kat? You got something?
I'm going to do a classic one because I just made brownies for House in the Park tomorrow night.
Hell yeah.
I mean, tomorrow afternoon, house music all day long. So Katharine Hepburn, always be yourself, never quit, and never put too much never put too much flour in your brownies.
That's
and
right.
I just make
because there's gluten in it. No, I'm just kidding. Because our food is straight trash.
Right. I just made some kick-ass brownies, but
straight trash. That's what I said there. I was like, it's straight trash.
Straight trash. I was trying to.
What about you, JT? What about you? I know you're jet lagged. But what you got for us? Something Parisian?
Look, we no. What my grandfather used to say, and they even say it in the African American church, and the race is not given to the swift, but to those that endure.
Exactly. Hallelujah.
That's
right. GLP1 evangelist out. We will see you next week. And just remember, you're not alone. It is not your fault. And have a great one, everyone.